Good morning, everybody. I'm very glad to be here today, and I want to thank Dr. Weinstein for inviting me to take part in this important conference. I'm going to start by talking to you about the concept of continuity of care between the hospital and the community in general, not particularly in heart diseases. I'll talk about the concept. I'll talk about how do we implement it practically in our region, in the Negev. Then I'll talk about the heart failure patient and share with you our services for the heart failure patient, about the scope of services that, by the way, are all directed by Dr. Weinstein himself. So let's start talking about continuity of care as a concept. So here are two definitions for the concept. It's a core value in medicine and nursing, defined as coherent treatment with seamless transition between providers, or treatment given by a team of healthcare providers with efficient transfer of information regarding health. There are several types of continuity of care. It can be longitudinal, it can be relational, or it has to do with management. What are the potential benefits of increased continuity of care? It starts with the improved quality of care itself, with improved patient satisfaction. It has to do with reducing ER visits and hospital admissions. It has to do with increased prevention services use and improved chronic disease management. The Ministry of Health published in 2014 its concept about continuity of care. It defines continuity of care as a key target nationwide. Continuity of care is for both admission and discharge. It sets framework for the ancillary tests in the hospital as well as in the community. It talks about medication continuity of care, about the discharge planning that is needed, and what is the follow-up after discharge. But several years earlier, the Clalit management published its own strategy regarding continuity of care. So several years earlier, Clalit decided that the interface between the community of a hospital should not be a burden or an obstacle, but it should represent an opportunity. And that chapter says, taking advantage of the hospital stay to strengthen the service medical value for the customer and for the care providers. The hospital stay is an unusual point in time in the relationship between Clalit and the patients with respect to the intensity of the interface. Understanding the concept, and it's important, let's talk a little bit about the implementation in our region, the Negev, the southern part of Israel. I'm talking about two organs of the same organizations of Clalit Health Services. One is the Soroka Medical Center, the Central Hospital, a tertiary referral center hospital in Beersheba, as well as the southern district of Clalit, representing some 580,000 people insured by Clalit, representing about 2/3 of the population that live in the Negev. So there are a lot of projects, actually, that represent continuity of care in our region. We start with quality indicators. I'll shortly show you some of them. But there are other projects. For instance, we have a joint forum for excision of skin lesions in order to decrease the huge amount of skin lesions. Telephone consultations between community and the hospital. Secondary prevention of osteoporosis is being practiced in our region. We are using hospital admissions of diabetes patients in order to complete routine tests that are needed. We are talking about outpatient echocardiography appointments that are set for the patients and provided to them before they leave the hospital. We have breast cancer coordinator, we have discharge planning. We are discharging the patients with the prescriptions at hand for drugs that are favored by the community, and then seeking approval for special medications before discharge. You know that some of the HMOs demand those approvals are given in the hospital before the patient is being discharged. And these are some examples of the continuity of care quality indicators that we have. Some ideas of them: bone mineral density for inflammatory bowel disease, colonoscopy for patients with family history of colorectal cancer, as well as patients with positive fecal occult blood tests, and so on. Now there are some slides showing you how we are progressing in some of these indicators over the last, let's say, 2 or 3 years in various quality indicators, like look what's going with bone mineral density for patients with inflammatory bowel disease, how we are making a progress. And when I'm talking we, I'm talking about the staff in the hospital as well as the staff in the community. Look how we decreased the number of patients awaiting excision of skin lesions within less than 2 years. Look how we are increasing the number of patients that are going through colonoscopy. Those are patients with positive occult blood tests. Another issue that we addressed is decreasing readmissions. You know how important it is for the patients, for the families, and for the entire healthcare system. So we are talking about ongoing activity in primary care clinics. We are talking about identifying populations at risk, contacting discharge patients, and we are talking about ongoing coordination of activity with the district for homebound patients. So having said all that, let's go into the issue at hand with the hospitalized heart failure patient and about the continuity of care, or if you want, the seamless transition of this patient back to the community. I will start with by talking about the burden of heart failure. Much of the data was already discussed here, so it will allow me to turn those slides quickly, because you heard some of the data already. So we are talking about disease that is common, about a growing number of patients all over the world. The estimates are that about 1 or 2% of all people have heart failure. And if we're talking about elderly, we're talking about 10% or even more than that. We are talking about 1 to 4% of all hospital admissions as primary diagnosis, and we know that recently survival rates for patients with heart failure have improved in many parts of the world, in parallel with the introduction of modern and evidence-based therapies and patient management systems. Despite these improvements, we should emphasize the fact that 2 to 17% of patients admitted with acute decompensated heart failure die while in the hospital, that 17 to 45% die within 1 year of admission, and that the majority die within 5 years of admission. We can still say that the outlook for heart failure patients remains poor, and survival rates are worse than those for various types of cancer. It also carries a high cost, about 1 to 3% of all total healthcare expenditure in the Western world. The lengthy and repeated hospital stays account for the majority of the economic burden. This is evident. And we also know that the average length of hospital stay is in between 5 to 10 days. The issue of readmission in Europe and North America, we're talking about 25% of patients that are readmitted within a month, up to 2/3 within a year. and usually for the same issue, for recurrence of heart failure. And this is a table taken from the guidelines for diagnosis and treatment of acute and chronic heart failure by the European Society of Cardiology. And here is what they say about pre-discharge and long-term management. Plan follow-up strategy, enroll in disease management program, plan to optimize doses of disease-modifying drugs, ensure assessed for appropriate device therapy, prevent early readmission, and improve symptoms, quality of life, and survival. Several randomized controlled trials of multi-professional managed care versus usual care have been performed, and various models of care have been investigating. Those included multi-professional heart failure clinics, multi-professional follow-up without heart failure clinics, telephone contact, primary care follow-ups, and enhanced patient self-care. And most have used specialist personnel, including cardiologists and heart failure specialist nurses within their multi-professional team. A systematic review of 25 of those trials already mentioned in this morning show that specialized multi-professional care in the clinic or non-clinic setting reduced mortality by 25%, heart failure hospitalization by 26%, and all-cause hospitalization by 19%. I think this is very, very impressive. The vast majority of the trials managed or systematic organized heart failure care have concentrated on patients who have had a recent admission to the hospital with heart failure. So guidelines now state that heart failure care should be delivered in a multi-professional manner. This is the main, I think, the main emphasis here. The establishment of heart failure management program should be a priority. All patients should have access to the best possible care, responsive to advances in diagnosis, management, and treatment, and the goal should be to provide a seamless system of care across both primary and hospital care so that the management of every patient is optimal, no matter where they begin or continue their heart failure journey. Several points regarding the heart failure management program. Service setup depend on, of course, the geographical location, the disease prevalence, the local limitations to optimal care, as well as the resources. The goals of the ideal heart failure services are to provide the patients with accurate diagnosis, correct investigations, implementation of appropriate evidence-based therapy, education for both patient and their carers, with the overall aim of improving survival and improving quality of care. Essential elements for a successful program would include specialist heart failure cardiologists, specialist heart failure nurses, ability to function across sectors of care, heart failure outpatient clinics, and adherence to the common and evidence-based guidelines. What about the medical staff? Let's talk about hospital cardiologists. We know that heart failure outcomes are better for patients when they are treated under specialist cardiology medical staff that can provide the exact or the accurate diagnosis, address reversible factors, start evidence-based therapy, treat comorbidities, and plan the long discharge management. And we believe that all hospitals should have a cardiologist with a specific expertise in heart failure. The primary care, cardiology primary physicians to support and ensure the optimum primary and secondary care interface for the patient, to include the primary care physician as an important member of what we were talking about, the multi-professional team. Nursing staff, specialist heart failure nurses reduce hospitalizations for patients with acute decompensated heart failure. Each hospital site should aim to achieve the European target of 1 heart failure nurse per 100,000 of population, and immediate access to the cardiologist with specific interest in heart failure. The multi-professional team includes not only doctors and nurses, but it includes all the professions that are mentioned here, pharmacists, dietitians, physiotherapists, psychologists, primary care providers, as well as the social workers. So what about heart failure in our region? Again, I want to remind you, I'm talking about Soroka Medical Center, a tertiary referral center, and practically the only hospital for the entire Negev region. And I'm talking about the Klalit Southern District that provides services to around 2/3 of the population that live in our region. So let's talk about the scope of services in the southern part of Israel. We'll talk about the hospitalization itself, about the outpatient treatment, the community unit, and its clinic. So let's start with hospitalization. We provide, of course, hospitalization of patients with progressing heart failure. We provide consultation for inpatients with new or chronic heart failure. And there is ongoing telephone consultation 24/7 for hospital physicians that need it. We have the heart failure clinic in the hospital, which provides follow-up, assessment, consultation, and medical titration. And we prepare patients for transplants and coordination with the transplant centers in the central part of Israel. The outpatient treatment in the hospital, it's for patients who require more intensive treatment after treatment in the unit in the community. I'll talk shortly about the unit in the community. So we provide basically intravenous treatment with the drugs that are mentioned here. And let's talk a little bit about the community treatment settings. We know that there are around 5,000 patients in the Negev with heart failure that live in the community. We provide heart failure treatment unit that includes professional assessment, optimization of drug therapy, intravenous treatment when it is needed, nutritional consultation, education of patients by specialist nurse. By the way, the nurse responds to phone calls from patients daily until 9 p.m. Constant contact with the hospital, consultations with experts in other fields, order for tests, transfer to outpatient system for more intensive treatment. The community treatment settings includes ongoing consults with community physicians 24/7, and the unit demonstrated a decrease of over 50% in the rate of repeated hospitalization and emergency room visits in the first year of its activities. This is actually the last slide in which I want to show you that during the last year we have a constant increase in the number of patients coming over to our treatment settings, and that the number is growing. You can see both the Beersheba follow-up visits as well as where the main emphasis is there, and you can see the growth even in the Ashkelon follow-up visits. And I would like to thank you for listening.